Welcome to Future Conversations, the podcast that explores research through the lens of tomorrow by Monash University Malaysia.
Welcome to Future Conversations. I am Emeritus, the Professor of Practice, Digital Media and Communication, Monash University Malaysia. In today's episode, we're discussing the financial, political and humanitarian consequences of the US leaving the WHO in January 2026. What impact will President Donald Trump's executive orders have on global health governance? Joining us today, Professor Dato Dr. Adeeba Kamarulzaman, Chief Executive Officer, Pro Vice-Chancellor and President of Monash University Malaysia. Also joining us, Professor Kent Buse, Professor and Director of Program Development, School of Medicine, Monash University Malaysia. And also with us, Professor Elil Renganathan, Professor of Public Health and Policy, School of Medicine, Monash University, Malaysia. A little bit of an introduction to Prof. Elil because we're going to be talking a lot about the WHO. Professor Elil has actually spent 25 years in the WHO, and in his last two positions, he was Director of Planning and Resource Coordination. He also took on the role as Director General Representative for Evaluation and Organizational Learning. Prof. Elil, tell us a little bit more about the WHO. I mean, it is a UN body that plays a crucial role in global health governance. The WHO oversees disease surveillance, setting global health standards, coordinates international health responses. However, it has no enforcement power over the 194 member states. So why is this unified health body so essential?
Thank you very much, Mira. WHO, I think it'll be important for us to get a sense of what WHO is. People talk about WHO. WHO is made up of 194 member states, countries who own WHO. And then there is a secretariat made up of staff who support WHO's work. So when people talk about WHO, there is this confusion. And that one comes back to the power of enforcement because it's the member state organization. WHO Secretariat serves the member states. Yeah. WHO has got a headquarters in Geneva, has got 6 regional offices and 150 country offices. So it's through that structure that WHO Secretariat helps implement WHO programs, puts forth and implements the resolutions, the programs, which member states have agreed upon. It's important to note what are the instruments that define WHO's work. Any given time, there's a general program of work, which is usually about 5 to 6 years. And within that context of a general program of work, which provides a broad context of health priorities, etc., there are biennial 2-yearly program budgets. And the program's budgets are the ones that come up with the work plans and identify what exactly is going to be done by WHO in that 2-year period.
So you see this unified body as essential,
yes,
to world health.
Important aspect is the fact that it's a neutral forum. It's the only neutral forum where 194 member states come together. There is an established governance structure, governance mechanisms through a World Health Assembly, through the executive board, so that and processes including resolutions which member states decide on in order to say, okay, what are the next priorities for health.
Professor Kent, Donald Trump's latest executive order immediately freezes all US government funding, resources and personnel working with the WHO. Now, we've heard of some of Trump's reasons for leaving the WHO, one of which is that, the WHO managed the pandemic badly, was one of the reasons, and that the US was contributing a bit too much. The WHO and China was not contributing as much or pulling its weight. Is that really valid? Do you think that's all? Do you think those were good reasons to leave the WHO?
Absolutely not. I think that none of the 4 reasons put forward in the executive order stand up to any kind of scrutiny. But I do hope as well that we'll come back to Elil's point about what WHO is and how essential it is in this conversation, because I think that WHO is also people like Professor Adeeba and myself, because another function of WHO that Elil didn't get the time to get to is that WHO is also several hundreds, if not thousands, of expert networks that come together and they develop global norms and standards around, again, thousands of issues, and they bring together the best technical evidence and expertise that there are, and they issue normative guidelines that countries can consider, they can adapt, they can adopt, and as Elil said, WHO and the experts that it engages, either on a voluntary basis or as consultants, support countries to adapt and implement them. So I think that WHO is a lot more than what we see on our television screens as a building in Geneva. It's a global network, or several global networks. President Trump, on his first day of office, signed the executive order that you're referring to. He, of course, had, during his first term, attempted to also withdraw the U.S. from the World Health Organization. On President Biden's first term of office, Biden reversed that decision because he recognized the value of this and the unique value of this organization to the health of Americans, but also the health of everyone else working, everyone else living on the planet, in effect. President Trump, as you said, gave 4 reasons, one of which was that WHO had bungled the COVID pandemic. I think we can come back to Professor Adeeba, who's the Vice Chair of the Science Council, on her views on that. But as a non-expert on these things, I think that it was only fair to say that most countries could have done better. If you compare the United States' performance against other countries, the United States does worse than most other countries. If you compare Republican versus Democratic states in the United States, the Republican states did worse. WHO, I guess one could say, maybe should have been promoting masks earlier on, but in their defense, they might have been trying to protect the supply for frontline health workers, for frontline police forces and so on. But that's not my area, but I would say that WHO has also undertaken assessments of its performance, and those assessments are in the public domain. So I don't buy that. The second one was that China was telling Dr. Tedros, the Director General, about how to run WHO. And I think that it's in the public domain. It's incontrovertible that Dr. Tedros has said both that he's repeated time and time again that the theory, the lab leak theory, all theories are on the table. And if WHO teams could be sent in, that those theories would be tested. And he's also repeatedly asked China to release data that China hasn't released. The question of funding, I think that's an interesting one. Not to get too technical, but there's 2 kinds of funding that come to WHO. One are assessed contributions and one are voluntary contributions. The assessed are about 20% of the budget, despite the fact that WHO has wanted to increase those because those are resources that it can spread around. Every country is assessed based on their GDP and population, how much they should pay. And so the Americans pay what they're asked to pay. On top of that, they provide voluntary funding that adds up to a lot and is disproportionate. And I think that other countries should step up their voluntary contributions and pay more. But if it's disproportionate, that burden for the United States, then President Trump should have negotiated around the voluntary contributions. I could go on, but yes. I would absolutely reject all of the thinking.
Reasons.
Yes.
Okay. The rationale for it.
Because could I just put forward my own?
In a while.
Okay.
Just give me a sec. I'll come back to you. Prof. Adeeba, what are the consequences? I mean, you work a lot in infectious disease. You work with tuberculosis, malaria, HIV. What are the ripple effects of this?
Yeah, where do I start? I mean, just to give a concrete example around COVID-19, for example, WHO was able to convene experts around the world on a platform trial very quickly to, at the time, no one knew what was the right treatment. And it successfully showed, I think at that time, it was hydrocortisone that it was testing, along with other universities as well, but particularly focusing on low middle income countries. The WHO was able to bring together experts and successfully conducted this trial that, told us what was effective for COVID. And secondly, it also created these living guidelines of distilling results of scientific evidence during COVID and putting it out there once again for low and middle income countries. And I think WHO has a particular mandate to assist low and middle income countries. And so without its presence, I mean, wealthy countries can go on and do these clinical trials through its universities and so forth, but it's the low middle income countries that are going to suffer. The other key aspect, as Ken said, was I've given you the example of bringing together evidence for use as guidelines for low and middle income countries, but specifically for Malaysia. Although WHO has a small presence here, but when needed, it really provides the assistance. And I'm specifically thinking about the rabies problem that we had a few years ago and the small polio outbreak, that once again, WHO can bring in expertise to help Malaysia at the time with the rabies outbreak. So these are not things that can easily be accessed by countries without the assistance of a body like WHO.
So if I may just add on, I think Prof. Adeeba has, guided us towards a nice area. In the Constitution, there are 21 functions for WHO. That kind of boils down to what 6 main functions, and that is quite good to see how that worked during COVID. One is leadership, providing global leadership, convening, bringing people together, etc. That's one big area where they did. The second one is shaping the research agenda. In that process, WHO, together with the experts, provided quite an important contribution as well. The third one is norms and standards. Setting of norms and standards. These are quite every one of us when we are traveling. Air pollution, water quality. All these are parts of norms and standards produced by WHO. Then, of course, you've got others like the policy dimension, articulating policies based on evidence. And that's also during COVID, some of this happened. Some of them took longer than were necessary, but it happened. On top of that, you've got what both Kent and Adeeba have mentioned, the technical support that they provide. So the technical support that WHO provides is through either its own expertise or expertise from other countries, rosters, GOAN, which was a global outbreak and response network, and that is at the request of the countries. WHO cannot parachute in, so it's at the request. And the final key function is monitoring of health data and health trends. And that was also quite an important piece of work that was done during COVID. And that's done regularly, all these 6 functions.
I'll come back to that in a short while because, the WHO has, the US contributes about $1 billion, which is about 18% of funding. But I'll come back to that. But what are the consequences of the US leaving the WHO, Prof. Elil? Let's say we have another global health emergency. Will the WHO then share data with the US and vice versa? How will that work? Would you have an idea?
WHO will always share information with every country that needs that information. So they will share that information with the US because US is part of the global community. Because if something is not going right in the US, it's going to be, there's no way, there are no borders for a pandemic, for example.
So let's come back to the 18% and $1 billion funding. How significant is that to the WHO? It does, in my mind, 18% doesn't seem like a lot. Can the WHO not make up or get other countries to contribute or find other ways of funding this? Because as Kent said, there's an assessed contribution, there's a voluntary contribution. Can't we just get this money from somewhere else?
Okay, so generally the US, probably going back one step, WHO's budget is divided into 4 pockets. The biggest pocket is called base programs. That's what is called the core work of WHO. Then you've got an emergency program. And then there's a polio program, and then there's special programs. It's like the tropical disease research program, reproductive health research programs, and so they come under that special programs. The billion or so that the US is providing or was meant to provide, 260 million, which is the SS contribution, will normally go to the base programs. But when you look at the totality of how the US have been funding, most recently, 40% of the money of that, whatever billion that they had spent, was spent on emergencies, 20% was spent on polio, and maybe another 40% was spent on the base programs. Now, if they take away the 1 billion, it'll affect emergency programs much more. It'll affect polio programs much more. Polio is en route for eradication. So the effect on polio eradication is going to be enormous. And that 200 or so, whatever, 20%, that's going to be quite a substantial amount when you look at a polio program which has got 700 million or so. So it does make a big difference.
Kent, do you want to add on?
Well, the only point I'd add there, or maybe a few points. One is that WHO has been under pressure for a while to both save money and to raise money. And Professor Elil can correct me, but I think that in the past biennium, there were savings of 150 million already, which isn't insubstantial, really. And so there have been efforts to cut costs. There have been ongoing efforts to raise funding, and there was the first investment round ever held last November, and is a glass half full or is a glass half empty, but it certainly could have been a lot fuller. And to answer your question. And so going forward, I think that a case can be made that some of the rich Gulf states could be contributing more, because as they're benefiting as everyone else, and so could the BRICS nations, and I think a lot of other nations could as well. The investment round is more for philanthropy and private sector, and I think that, as we found out during COVID, a pandemic affects the economy very generally, and so the private sector should be more interested in. At the end of the day, it ought to be member states that are funding this, but in a crisis situation, I think that extra. Hopefully I can be as hopeful as you are that the extra 20% can be found, but the 20% is critical. It's really critical. And it's not just the money. It's and Professor Adeeba might come in on this. The entire organization is affected. It's destabilized, and it also the directives from the American administration have been to bring home all of the professionals that had been seconded from the American administration, from the CDC and the NIH and so on, to bring them back home. What is the impact of that? It's going to be profound.
It is going to be profound. And I don't have the numbers off the top of my head like Elil does in terms of these professionals that Kent has just mentioned, but just the very own small program that I'm involved in, which is the Science Council, that funding comes from, a lot of that funding comes from the NIH. And we've worked on a few special projects, including the genomics report, which is to advise member states on how to adopt genomics technology in lower middle income settings. And a report that's sitting about to be launched is on digital health. So who knows what's going to happen to that? And all of us, members of the Science Council, doing it voluntarily, but there's a very, very small secretariat that I dare say will also be affected. That's just one small example of these big issues that we are trying to deal with that's going to be heavily affected. But you've heard all the other things that...
I would just say I was in Geneva last week at an expert meeting. Dr. Tedros has asked for belt tightening, and what translates into is no travel, no meetings, no renewal contracts, no new contracts. And so if Professor Adeeba's committee wants to publish their report...
There's no money.
There's no money.
And no one to especially if the staff is seconded from the US, there'll be no one to actually do it. And we've spent a year and a half putting together this report.
My question then is the WHO running efficiently, Prof. Elil?
That's a difficult question.
I've had somebody describe the WHO to me as a bureaucratic beast. Is that an exaggeration?
Coming back to what I'd originally said, it's a member state organization. So it's going to be bureaucratic, yeah. And WHO staff are called international civil servants, and I do agree that there's room for efficiencies, and there have been various reform processes where people have tried to address that. One of the major reform processes that was led by member states looked at three things. One was programmatic priority setting, second one was governance, and the third one was sustainable financing. So you can already see that in those three areas, there are inefficiencies. Yeah. When you look in terms of administration, management administration, it's about 10% of WHO's budget that goes for management administration per se. So you can then try and compare and see, okay, is that efficient or is that inefficient? I think the organization has got a couple of inherent inefficiencies, which are more political rather than something that we can solve. It's the one agency which has got 6 elected regional directors. All other UN agencies have got appointed regional directors, appointed by Director General or the head of that organization. So that's one area. So having 7 elected officials, you can understand that it's not always going to be very smooth sailing. There's a lot of discussions and wanting to come to agreement. Member states thought about it during one of the reform processes, but decided not to touch it because it was part of the constitutional makeup of the organization. And those are, and then you want to look at how WHO functions in terms of how much work is being done at headquarters, how much work is done at regional offices, how much work is country offices. There's a strong push towards more work being done at country office level, reducing the footprint in Geneva, because the Geneva footprint is the most expensive footprint because of the Swiss expenses. And there's been a push towards mobility. When you sign a contract in WHO, there's a clause that says the Director General has the authority to assign you to a task and a position anywhere in WHO, or respond to the needs of the organization. But that doesn't get applied, and staff who are already in Geneva do not want to leave. So mobility gets. So those are areas where you could do something about. There's been a strong push towards having more accountability. So the accountability functions are being strengthened. That's good. There's a push towards moving more of the administrative functions towards low-cost areas or sites. There's a Cyberjaya here in Malaysia, hosts one of the management administrative centers. There's a center in Tunisia that covers travel. So all these are having probably the same number of staff that are necessary in Geneva, but then at a reduced cost. So those kind of things are things that one could do. Ample opportunities for further efficiencies as well.
Has the organization gone through a similar situation where funding has been a problem?
2011, following on from the 2008-2009 financial crisis and 2009 H1N1 outbreak, the organization really had financial problems. And in the January EB of Executive Board of 2011, where member states talk about the programming for the next 2 years, 2012 and 13, member states basically said, listen, no, we cannot go with this budget. The budget has to be reduced. So there was a reduction of the budget of 800 million. So budget is not money, but budget is what frames the work you will be doing. So because of that, the organization had to step in, do 3 really key measures. One was priority setting, the second was cost cutting, and the third one was diversifying of funding. Around the same time, there was also a reform that took place, which was looking at these issues, prioritization, governance, and financing. What did prioritization mean? Prioritization meant that was a time of the MDGs, Millennium Development Goals. Prioritization meant that, any work would be done in that year or the next biennium had to contribute towards MDG. So that was already one level of prioritizing. Cost cutting came in the form of, again, as it is happening now, travel, no extension of staffing, no extension of contracts, no extension of retirement. We had surge capacity. We had a lot of, from the previous outbreak, H1N1 outbreak. So there were a lot of consultants around. So about 1,000 people were let go in that period, 500 in headquarters and 500 the African regional office. So those were drastic things that were done. Yeah.
Can I just come in though? Because I was going to. One of the 4 rationales put forward by President Trump was around the bureaucracy, the inefficiency of WHO. But I just can't help myself from feeling this was a red herring. This is the same administration that's just, Musk was proud of putting USAID through the shredder, as he put it. They're trying to dismantle the Consumer Affairs Bureau. They're trying to cut the federal workforce. This is just part of a much wider agenda that is basically anti-regulation. They don't want to take rules. It's anti-multilateral. So in terms of WHO, yes, any organization can run more efficiently, even Monash University, I dare say. In fact, under Tedros, and I don't want to be an apologist, there has been an effort to introduce at least 40 reforms that I'm aware of under Dr. Tedros at the urging of several donors. The WHO joined the International Transparency Initiative. During the past 3 years, it's improved by 10%. So it's in something called good. It's in a good category now, whatever that means, but it's better than it was. So there have been efforts. And had the issue really been around what to reform in WHO, President Trump could have used his muscle to engage in those conversations. But, it's just another one of, it's a red herring. And in fact, yes, there should be reform, but it's quite a distraction. It's a diversionary tactic from us talking about, you have 3 health professionals sitting on a couch here on these sofas talking about something that we shouldn't be wasting our time on, really. We should be supporting WHO. And it's, I'm sorry to say, but it's, sorry. Yeah, go on, Elil, you want to come in?
No, I think you raised a very important point about being IATI compliance, the International Aid Transparency Initiative. WHO is among one of the few agencies which has got a web portal, WHO Program Budget web portal. Anybody can go into that web portal and see what money has come, from whom, how is that money being spent, for what outcome. So I don't think you can get any transparency beyond that. Yeah, maybe the metrics of saying, okay, how successful were you? But that's being then produced in reports later on. So that's the transparency answer. And it's good that you raised that IIT.
Prof. Adeeba, the Global South has always been dependent on the Global North for funding, for resources, and all of that. How can we do better? How can the Global South take more control over the health?
I mean, I think as you've sometimes hear people say, never waste a good crisis, right? This is really a time for countries, member states, to take notice and take charge and no longer be dependent on one country. I mean, there was a really good editorial from in Nature, I think the science publication, that an African scientist, how can a continent of 1.2 billion people be relying on just one country? And I think he's got a point. We've just become addicted to that easy flow from the US, and it really is a wake-up call. Having said that, it's not going to be so easy, because not only, I mean, we've spent the last 40 minutes speaking about WHO, but those executive orders have also gone to USAID and PEPFAR and a lot of other programs that millions of people are dependent on, and lives are at stake. I think, yes, first of all, as Kent said at the very beginning, regional bodies like, or maybe not regional, but other large multilaterals like BRICS and should step up. Very well, regional countries, sort of a group of countries like the Middle East that are wealthy should step up, but individual countries also should increase their contribution. So, I think it is a wake-up call for all the countries, and it's also an opportunity for South-South collaboration, whether it's in research or in exchange of ideas and exchange of technical expertise. The role of universities, I think
all three of you, in public health, how can we better public health courses in universities? How do we refine that in terms of research, in terms of the study of public health towards, the larger good?
I think that's what we hope to do here at Monash University Malaysia, where Kent is here with Sarah Hawkes to help us develop a global population health program that's relevant to low and middle income countries, that speaks to developing expertise in country and within the region, for the region. So there is already a lot of expertise. I think through the years, we've developed this expertise, but for low and middle income countries to take on these sort of independence, I guess, building that, we need to continue building that leadership capacity, that technical capacity, which I hope this program is going to address.
Well, yeah, I'm very optimistic. I think that there's a huge opportunity to think about the kind of societies we want to live in, and to see where maybe some societies haven't gone so well over the past 20 years, what accounts for the inequalities that we see around us, and providing alternative narratives and visions. And one of the things that I'm quite passionate about is what can we do to keep people from falling sick in the first place, and investing in what are called the social and structural determinants of health, and that not enough investment has taken place there. So I think we have a huge opportunity to work with the next generation to maybe even reimagine cooperation and multilateralism. But it would be a shame for it to cease to exist because of one member state pulling the plug so dramatically and so quickly. We need to help WHO and these other organizations get through it. As we rebuild and as we reimagine a different kind of future that will keep us all healthy and well, and by that I mean the well-being of not just people but the planet as well. So making those connections.
In terms of the Global South and leaders of the Global South, how can they play a better role in terms of empowering and enabling scientists, research, all of that, Kent? I mean, leaders of the Global South play a big role as well.
Are you referring to political leaders or leaders in general?
Everything, actually, really, from top to bottom. I think leaders all along the way need to empower people to make decisions and, go into areas in which will contribute towards the betterment of, people living in the Global South.
Precisely what Ken just said, right? In terms of, this is also a time to refocus instead of sick care, which we are addicted to again, to investing in prevention, investing in community strengthening, investing in community health workers, something that we don't do very well. So there are many opportunities to kind of think out of the box and look at health and health systems differently.
Okay. Your message on the future of public health, given, we have executive orders coming out, as we don't even know if there are more coming out soon.
This crisis is an opportunity as well. I think there's a strong recognition, and the Global South is beginning to work together. Africa is a good example. They work very strongly together in WHO meetings, etc. They have common views. They've got common positions. The African CDC, is basically taking over the responsibility of public health in their country, as in their continent. I think we need to start in ASEAN. I think the regional groupings will start to play more and more an important role. I just think for public health, we just need to make sure that there's a lot of learning in countries like ours. We sometimes do not realize that Malaysia, for example, is pretty good in terms of public health is concerned. There are issues, there are problems, but in general, so build on what's good, improve on what's not good, get learning from other regions, and try and collaborate. And I think this is also an opportunity for more expertise and resources being exchanged between countries of the Global South.
I think what Elil just said is really true. That when I go into these global forums, often feel very acutely the difference between the solidarity and the expertise that exists in the African region compared to Asia. And I think it's many reasons for that. But with Malaysia taking on the chairmanship of ASEAN, maybe it's one of the things that Malaysia can really play a big role in seeing how we can bring member states in this region together to address this very issue.
Ken, what would you like to leave us with?
Well, I don't want to speak around the regional issues. It's more around the role of universities to protect scientists and protect science, and that in the current environment that we're in, there's a lot of disinformation, and that we need to redouble our efforts to promote and protect science and ensure that we invest in science, but also think that we need to be less complacent about the role that science can play in bettering society. We see how science can be hijacked, and so I think that we need to do better in schools of public health in relation to protecting the process of the translation of science into policy and supporting policymakers to work with the science and to understand and work with the science, because there are a lot of forces working against that right now.
So maybe it's a wake-up call for everyone, band together and work towards and not be reliant on some people, politicians. Thank you all very much for joining us today. That was Professor Dato Dr. Adeeba Kamarulzaman, CEO and Pro Vice-Chancellor, as well as President of Monash University Malaysia, Professor Kent Buse, Professor and Director of Program Development, School of Medicine, Monash University Malaysia, and Professor Elil Renganathan, Professor of Public Health and Policy, School of Medicine, Monash University, Malaysia. This has been Future Conversations.
You were listening to Future Conversations, a podcast by Monash University Malaysia. For more information, email mum.media@monash.edu.